Hi, this is Becca Wartig, and this is my persuasive speech. Okay, so I'd like to discuss total hip replacement, direct anterior versus posterior, and how it affects our hospital. The survival of our hospital is dependent on developing sustainable surgical programs that attract both patients in the community as well as those outside the immediate area. Surgical programs such as one for total joints, a high volume procedure that continues to grow in need, is an effective way to help with profitability. For the past 3 years, total joint replacement has been second only to knee arthroscopy in the volume of elective cases performed. The hospital has engaged with consultants that will help to further develop this robust service and continue to grow our volumes. These consultants have suggested effective ways to attract and support our patients. They encourage evidence-based medicine as the backbone of clinical excellence. Our patient outcomes for total joint replacement are excellent. As we move forward in growing this program, we should remember that it is excellent patient outcomes and experiences that will cement our hospital as a regional choice for joint replacement. There are several approaches to hip replacement, and one in particular has gained a lot of attention lately. The direct anterior hip replacement is a relatively new approach to hip replacement. Patients now more than ever spend time researching their procedure on the internet. Often they will have an idea of what they think would be best for them when they walk in the physician's office. While it's important for patients to know what they want and to take steps to research their procedure, it's also important for hospitals to be responsible in their offerings and inform the consumer of such. While new techniques can eventually become the standard of care, it's important to carefully evaluate the relative benefit. Such is the case with the direct anterior approach and its appropriateness at a small facility. I'll refer to these slides here. So the direct anterior approach is a minimal incision on the anterior aspect of the hip. And the posterior is a much larger incision on the back side of the hip. The main case for the direct anterior approach is that it lowers the risk of dislocation in the early postoperative period. According to Rodriguez, Cooper, and Robinson, the dislocation rate for posterior hip replacement is upwards to 4%, and direct anterior is closer to 1.5%. Dislocation is not only painful to the patient, it can alter the long-term outcome for the hip replacement. In addition, patients eager to get back to their activities are often concerned with the restrictions on movement that come with the posterior approach and its risk of dislocation. These restrictions are short-lived. Once the capsule is repaired, the patient is no longer at risk. In a study done by Rodriguez, Deschmuk, Rathod, and Grease, functional outcomes were better for the direct anterior at 2 weeks, but exactly the same at 6 weeks after the capsular healing was complete. So this slide just demonstrates some of the differences between the hip precautions and what that means for patients. Primum non nocere, or first do no harm, is a phrase often used in medicine. When making any responsible clinical decision, this should echo in one's head. This phrase is certainly at the core of how to approach the complicated issue of introducing new services at a small facility such as ours. We succeed when we put the safety of the patient first. Small community hospitals do not have the luxury of even one poor patient outcome. In small communities, the reputation of the hospital is often dependent on what is said in the grocery store line or how grandma did. We cannot risk one bad outcome, not only for the ethical implications of harm, but also for the health of our facility. There are a couple clinical nuances that make the direct anterior approach a challenge both from an intraoperative perspective and from the perspective of nursing management. These nuances are important as they could be problematic for the institution. While we have a robust joint program, we do not have the surgical volumes of a teaching facility, which will make it difficult for us to overcome these obstacles. One of the primary concerns with the amount of cases it takes to become proficient with a repair. In a letter to the editor of Acta Orthopedica, Spons reviews several articles that cite the learning curve as anywhere between 20 to 60 patients. One states that there is a decrease in complications only after 100 cases. There are reasons for this. The small surgical field makes visualization of the approach really difficult. The avoidance of important vascular structures and nerve bundles without direct visualization is challenging. Patients that are obese are particularly challenging. Special equipment that allows for dislocation of the hip requires getting used to. It's important to note that our small facility does 80 to 100 total hips a year, high volume for a facility of our size. Our small numbers pose a problem for a procedure with so high a learning curve, as it means that a large majority of our annual patient load is at greater risk for complication during this learning curve. Spons notes the following in her correspondence. Any surgeon who considers to change the approach for hip arthroplasty should be aware that this very likely will result in a longer operation time and higher complication rate in not a small number of patients. The other important concern is less about the patient and more about being fiscally responsible in this changing healthcare climate. In order to effectively perform the procedure, it is helpful to keep the leg in traction while dislocating in a specialty table designed for the procedure. I'll demonstrate that here. This is a picture of the HANA table required for this procedure. While some surgeons have been able to modify the procedure in order to use a standard operating room table, it's recommended that until the surgeon is comfortable, it's better to use the HANA table. At the 2013 ARN convention, I heard a nurse speak about the development of an anterior hip program at her facility. She stated that the surgeons that used the dislocation table, or the HANA table, were able to overcome the steep learning curve faster. In Pogliacomi, Parakepoulos, Constantino, Margeni, and Cesarelli's paper about the learning curve, they stated, we consider this, and by this they mean keeping the patient's leg in traction, important during the learning curve period as it facilitates hip and leg movement, visualization of the surgical field, and component positioning. The HANA table is approximately $100,000 worth of capital expense and requires one RN to be specifically assigned to the management of the table. In additional, RN is significant as the pay grade is much higher than another ancillary healthcare worker. OR time is charged by the minute, and the staffing ratios are calculated within that charge. Medicare will reimburse at a standard rate. In other words, a hip is a hip is a hip, regardless of the approach, and does not account for additional staff needs. All of the literature I reviewed stated that the surgical time for the anterior hip is significantly longer than the posterior due to the technical difficulties of the surgery. This returns to fiscal responsibility. Increasing the time in the surgery increases the cost to the patient and the insurer. When the patient is Medicare, it increases the cost to the hospital, where Medicare doesn't account for variations in the procedure. Financial viability is a struggle for a small institution such as ours. We need to provide safe healthcare to our small community, as well as being responsible with our taxpayers' money. We owe it to the community to be fiscally responsible. I propose that we continue to offer hip replacement using the posterior approach. We have successful results, excellent reimbursement, and a proven product. While we may lose a percentage of our patients who specifically want the direct anterior approach, we benefit by maintaining our reputation and our outcome record. This is much more important to this hospital than a small degree of outmigration. Our hospital will be successful when patients choose us not for the latest trend in surgical technique, but rather for our long-term outcomes. Our community will support us here at the hospital when we show that we provide a viable service that puts our patients' safety first. I urge you to support our total joint program in sticking with the posterior approach for our patients. In conclusion, we look at ways to develop programs at this hospital. We need to ensure that we weigh what works best for us with current trends in practice. It behooves us to look carefully at the evidence in the literature to evaluate the feasibility of changing the way we offer services. In the case of the direct anterior approach, the literature makes it clear that a facility of our size takes a great risk if they are to offer such a service. We do not have the volume of patients, nor are we able to mitigate any loss of our excellent reputation. Thoughtful program development is key for us and worthy of our time. Thank you.